This is, of course, the science and research update on outcomes after cerebral hemispheric surgery. I am the moderator for this session. I'm George Ibrahim. I'm one of the neurosurgeons at the Hospital for Sick Children in Toronto. And we have a very, very ambitious program for the evening, and it's one that I'm very excited about. Many of the speakers that you'll hear tonight really are world experts, and I, for one, am extremely keen to hear their insights and to learn from everyone tonight. Before we begin, I thought maybe it would be appropriate to give Monika Jones a round of applause for bringing us all together tonight. Monika has lost her voice. Hopefully we can convince her to come up here at the very end and give us some thoughts. She certainly needs no introduction. She is the founder and director of the Pediatric Epilepsy Surgery Alliance. She's principal investigator of the Global Pediatric Epilepsy Surgery Registry, and she is the person who brought us all here tonight. So it's a wonderful opportunity to all be together among friends. Shared many stories and many experiences with both of them. They're both wonderful, wonderful friends of mine. I'll introduce both of them as they come up and give their talks. But Arya is a pediatric neurosurgeon at UCLA, and Taylor is a pediatric neurosurgeon and chief of epilepsy surgery at UPMC Children's Hospital of Pittsburgh. And suffice to say, both of them are people that I hold in extremely high regard, and really world experts when it comes to the surgical treatment of pediatric epilepsy. So, gentlemen, please.
Thanks everyone for joining us. These are slides that Monika prepared that we're going to be sharing with you. But just wanted to say, just very briefly, this is the first time the Pediatric Epilepsy Surgery Alliance is doing a session like this at AES, and this is an incredible organization that serves so many of the children that we serve. So we're very excited to be here. Both Dr. Abel and I actually this year joined the board for this organization, and super excited to help it grow and serve more children. So we're going to be discussing some of the results through the Global Epilepsy Surgery Registry. That is a patient-facing registry, which is very important because, as all of you imagine, so many researchers in this room, epileptologists, neurosurgeons, and more, most of the research that we do is based on outcomes that we feel are important. So for the first time, this is going directly to the families of patients with epilepsy surgery. And for tonight's talk, we're going to focus on the patients that have had hemispherectomy surgery. So in this registry, which is also important to note, this is sort of promoted mostly through social media, and by social media, mostly Facebook. We have data on 174 hemispheric surgery participants. This is self-reported data, and 85% of them are seizure-free, so keep that in mind. Very interesting to some of the neurosurgeons in this room that when patients have hemispherectomy surgeries, just almost about 40%, over 30%, have more than one hemispherectomy surgery, so which means that the initial surgery fails. And if you look down here, it's not an insignificant number of patients that have 3, 4, or more surgeries. I once heard of a child who had 5 or 6 hemispherectomy surgery attempts. So, hydrocephalus is the number one problem that families have identified as a issue post hemispherectomy surgery. We actually had a PCORI funded meeting several years ago in Cleveland, and this was identified as the biggest concern that families had. And in this database, 25% of them had hydrocephalus after hemispherectomy surgery, which seems like a very large number, but that could also be because of some selection bias of the patients that decided to fill out the survey. And keep in mind that a large proportion of these patients have hemimegalencephaly, so about 40% of them do, which we know, and we'll talk about it later tonight, may be a risk factor for hydrocephalus. This is a very interesting slide. If you look at the green and the purple, the green signifies before and purple signifies after hemispheric surgery. But if you look at it, a lot of these patients have pediatricians before and after. Most of them have neurosurgeons and neurologists. But following surgery, a lot of them require occupational therapists, physical therapists, speech therapists, ophthalmologists, neuropsychologists, and so on, rehab physicians, orthopedic surgeons. And we are not preparing these families enough for what lies ahead following a hemispherectomy surgeries, especially as neurosurgeons. We do talk about hemiparesis, we talk about hemianopsia, and if we're on the dominant side, we do talk about some language difficulties, but there's a lot of issues that our patients face, and we want to make sure that we're setting them up with the appropriate specialists. In terms of vision diagnoses, if you look at it, pre-surgery, just less than half of these patients have visual issues. Now, these are sort of subjective, right? We're just asking families a very non-specific question. Does your child have visual issues? And we see 88% of them report having homonymous hemianopsia. We're actually surprised this number is not any higher. It's probably families that don't recognize that their child have this problem postoperatively. And you can see strabismus, amblyopia.
Neither of us are ophthalmologists.
Yeah, so, and in terms of vision treatments, you can see quite a range here. So 32% vision therapy, eye patching, eye muscle surgery, eye exercise, prism glasses. I'd say most of us don't even have a lot of our patients postoperatively seeing an ophthalmologist, let alone even being diagnosed with the right conditions. Hearing issues is a major problem for major challenge for many of our patients that we serve. If you could look at it, pre-surgery, 31% report hearing issues, and post-surgery, about 2/3. And in terms of the actual diagnosis, the diagnosis that's most common is the central auditory processing disorder. For those of us that are not audiologists, in very simple terms, this is the difficulty or inability to localize conversation, right? And so in a room such as this, if you can imagine several people are talking at the same time, it's very difficult for our children to focus their attention on one conversation versus another. And this is very challenging if you think about these children, especially in a classroom setting, right? It causes major problems and difficulties with learning. Do you want to take a few?
And I guess one thing I would add is, other than just simply auditory localization, which you'll definitely lose after a hemispherotomy, which is often something we don't even test for, these are patients that have lost half of their brain's auditory cortex. And we have no idea in the auditory science community how these brain regions reorganize, and also how losing these brain regions influences learning, which has major implications for occupational and educational outcomes. And so another medical outcome of hemispherotomy that is largely unrecognized is endocrine outcomes. And so the survey results show that 28% of patients had endocrine symptoms prior to surgery, but up to 92% had endocrine symptoms after surgery. And so these symptoms included excessive weight gain, excessive hunger, lack of weight gain, or lack of thirst. And it's really important to recognize that these things can happen after hemispherotomy. It's not just the seizure frequency that's going to change, but it's these other medical things as well. And these are patients that reported having primary endocrine diagnosis of early puberty after surgeries, 13%. Compared to less than 1% in the general population.
Just one thing to add. So normally it's 1 in 5,000 that have early puberty. So 13% is significantly more in terms of multitudes more over the normal population. So that's something to keep in mind.
And there's very little research on this. This is some work that was published from work done by the Pediatric Epilepsy Surgery Alliance in collaboration with Dr. Zeitler. But there's more that we need to understand about this. Autonomic symptoms are also commonly reported in the registry. This includes overheating easily, high pain threshold, blushing or blotching, discoloration or purple fingers, flushing that is warm to the touch, and also in other circulation problems. And so this is an example of what one family recently sent to Monika of some discoloration in the hand.
Just let me add, so for the autonomic symptoms, I feel some of these symptoms are non-specific, so sometimes causes challenges with attributing these symptoms to hydrocephalus. So there may be children out there that may be getting surgeries for hydrocephalus, or vice versa, where these symptoms are not being diagnosed appropriately and may be due to hypothalamic pressure from third ventricular enlargement. There's also, as many of you know, neurosurgeons in the room, when you do a frontal-basal disconnection and you're right close to the hypothalamus, you can give a hypothalamic injury to some of these patients, and they have a lot of these issues as well. So something for us to recognize as well.
Also, since you're dealing with hemimegalencephaly, it may be the underlying genetic cause, which is somatic mosaicism, that other parts of the body are also affected.
Absolutely.
Families also report issues with foods after surgery. This is 55% of the registry. This can include objecting to certain textures of food, avoids foods that most peers enjoy, doesn't like foods that are hot or cold, or gags or gets easily nauseated. So another thing is use of the opposite hand is, in my experience, almost always affected. But these are the responses from the registry that show how these effects can vary to a different degree. Some patients are completely unable to use their opposite hand. Others are able to stabilize weight or place an object in their hand. But the outcome can vary widely, and this is something that isn't always discussed with families prior to having surgery. And the rehabilitation strategies to improve function after surgery can be extremely expensive. And so it's important to recognize this before and after surgery and deal with it as appropriately as possible.
For those just at the back of the room, the 5% that's down here are the patients that have independent function of that other hand. So that's the only, so that everyone's striving for that, but very few patients actually have that independent use of that hand.
78% of individuals in the registry wear orthotic devices on the upper extremity. 95% wear orthotic devices on the foot, feet, legs, or hip. 26% had to have surgery on bones, muscles, or nerves. And this is some foreshadowing to Emily's presentation, which we'll have next. And children are more likely to see an orthopedic surgeon over the long term.
No, so many of these children require orthopedic surgeries that, again, we're not really preparing for them in sort of ahead of time. This is a topic of major importance: social well-being, psychological health. A lot of the patients have anxiety and anecdotally depression. And if you look over here, autism spectrum disorder reported at 20%. I would say that's probably much higher. Keep in mind, a lot of the patients that have filled out this registry, their kids are still in the 1 to 2 year range. So they may not have been formally diagnosed. But there's many challenges that these patients face as well that you can see listed here. This is again, one of very few articles published on functional, cognitive, and language outcomes. So again, we're not going to discuss it here, but something if you're interested to read on. We can Next one. Okay. Thank you very much. So we had a lot of help, folks that contributed to this, and especially Dr. Puka, who is the biostatistician that helped us put all of this together.
So, I think this is really, really remarkable. Just to give folks context, I've been in practice for 6 years, 6.5 years as a practicing neurosurgeon. When I started 6 years ago, I never spoke to any family I saw in clinic about any of this. I never mentioned endocrine function, the need for orthotics, issues related to neurocognitive issues after a hemispherectomy. So this is really, really sobering, and in the process of informed consent, obviously this has a lot of implications. So this is the fun part. Any questions for Dr. Abel and Dr. Fala? Or thoughts or ideas, compliments? Perfect. We have one just in the back here.
Hi, I'm Matt Lawless. I'm one of the epileptologists at the Nicholas Children's Hospital, and I've been fortunate enough to work with Dr. Fala when he was in his fellowship, and I was also in my fellowship, and with a couple of other people here attending. I think this is really, really important data that you're right, is not well investigated previously, that we didn't really have good understanding, and it's absolutely counseling issues that need to be presented to the families. And sometimes it can be hard for them to hear, your child's going to need to be seeing an orthopedic surgeon one day, is going to need lots of therapies, and really understand the implications of all of that. I would challenge a little bit the comparison of a population that is, so heavily weighted towards large brain malformations to normal healthy controls. I think if we take a look at, children who have widespread neurologic injury from HIE or from TBI, you're going to also see a fair amount of endocrinopathy. And I think that you're also going to see some of those similar processes for needing to see an orthopedic surgeon. And often actually when I don't often end up in the NICU because that's just not what my role usually is. But on the rare weekends when I am covering the NICU and I'm dealing with counseling a family about some significant HIE and the long-term implications about that, I bring some of these things up without the kind of literature and numbers that you're getting here. But I think it is important that we keep in mind the comparison is not completely perfect. Nonetheless, this data didn't really exist before, and the parents need that information. So
I'm going to do my best to respond to your question, Dr. Lawless. What we hear from the families is the message that after surgery, the brain will reorganize and your child will be, normal. They'll have some hemiparesis. On Friday, People magazine published an article that I was quoted in around a girl who had hemispheric surgery. There was also a local news story, again, and it's always the same message, that the good hemisphere will take over the functions and you'll just have a hemiparesis. We are certainly not saying that these children should not have these procedures. They need them, but the parents deserve a roadmap of what can be expected postoperatively, what clinicians they should see. They should not be compared to typically developing kids. And, I can speak from my personal experience. It feels really awful when your child does not have the outcome that you were pointed to because you feel like you're not doing enough as a parent. So if I had only had a roadmap afterwards, it would have been very helpful. So that's all we're asking for here, certainly. I think the whole room could say, I don't know if there's another proponent of epilepsy surgery other than this group. We want these kids to get to surgery if they need it, but post-operatively, they need a roadmap in regards to recovery.
I just want to add one thing that we didn't show here, but one of the questions also is, we commonly ask is, are you satisfied with having surgery? And overwhelmingly, the answer is yes. Like, yes, I would do this. I would do it earlier. I would do it sooner. I wouldn't, it's not universal. There are some there, but that, regret the decision. But the vast, vast majority say absolutely. So yeah, we're not just to echo Monica's points, we're not showing this to sort of say, look, there's, we shouldn't be doing this in any way, but maybe if we can focus some of the research, right, and sort of guide things that are more patient important research questions as opposed to things that we obviously, I think there's a large number of neurologists and neurosurgeons in this room, and we do research on the things that we know something about, but maybe just advocating in the medical community on these topics that I think are less well studied, but very important to these families and patients.
Okay, I think there is one other question back here, and then we'll take one more question, and then we'll move on.
Thank you so much. This has been really eye-opening. It's wonderful to see, and I appreciate the comment earlier. I also appreciate some of these things. Families who have refractory epilepsy should be given that, whether they're getting a surgery or not. There's lots of counseling opportunities in the future. So my question is, how might this change your practice today?
May I ask, introducing yourself?
Sorry. Andrea Wilkinson, Global Head of Patient Engagement for Epilepsy and Rare Syndromes at UCB.
I can speak from my own personal experience. The way that it changed the way I interact with patients is these are now things that I review with every family before surgery. And the other thing we've done is, one thing we noticed when we started our program in Pittsburgh and we started doing more hemispherotomies, one thing we noticed is that before our program, everybody went to Cleveland for their hemispherotomy and then came back. Those patients were best served in our spasticity clinic because the spasticity clinic had a rehab doctor, a neurosurgeon, a physical therapist, an occupational therapist, and a neurologist. And so these patients, they got their surgeries elsewhere, but then they got this great multidisciplinary care when they came back. And so what we did was we actually started an epilepsy surgery clinic that does the same thing, but is completely focused on children who need epilepsy surgery. And so they're seeing all these folks before surgery. They're being told what rehab's going to be like before they get the surgery. And then they have the experience of going through surgery. And what we say up front is surgery is not the end goal. It's going to be one thing that happens in your child's care, but there are going to be all these other things that we're going to have to look after afterwards. And I think it really helps families get through it. And so those are the main ways that it's changed my practice.
Wonderful. So we have one more question, please. Oh, okay. Then we have one more question next door, please.
Hi, Nicole Murray. My son had hemispherectomy surgery. I'm on the board of the Pediatric Epilepsy Surgery Alliance. Maybe a comment, maybe a question. So my son has had many of these challenges, but I also wonder, had we not pursued hemispherectomy surgery, would the challenges not be the same for him? And I think sometimes, we think about surgery or no surgery, but have we also thought about the implications for refractory infantile spasms and, multiple seizures, 30, 50, 100 seizures a day? And might these same challenges have been his, trajectory as well? And so it's sort of, we have to think about the alternative as well. To your point, Monika, and to your point.
That was largely why I brought it up, because those demographics are different. But, and to your point, Monika, I again agree with you that we need to be counseling better and more careful about the expectations for families. Absolutely true. The long-term implications of daily seizures, 2,300 a day, will be disastrous. But ultimately, again, we didn't have these numbers. We need them, so we can provide them.
For those of you that went to Dr. Granovetter's poster yesterday and talk today, one thing that was really important from his paper is that etiology plays a really important role, more important than time to surgery. And so the etiology is crucial, but I don't think we understand the role of each individually, and I'm not sure we'll ever be able to do that study in a high quality way.
No, I think we can move on. Yeah.
So I will say, as in my moderator role, that the fact that we're having these conversations, in my view, is a huge advance from when I started in pediatric neurosurgery 6 years ago. We weren't even having these conversations. So really unbelievable work.
Hi, I'm JoJo Young. I'm a peds epileptologist at University of North Carolina, Chapel Hill. And my question is, so I love the idea of the roadmap for what families can expect afterwards. And I also wonder about interpreting it as a quality measure. So for example, like those AAN quality measures for, infantile spasms, et but that this should be kind of the not necessarily if surgeons are seeing them maybe once or a few times post-operatively, but the neurologists afterwards that are seeing them long-term have, a checklist of these are the quality things like optho, endo, PMNR, et cetera. Because, we do that often for things like HIE and family organizations like Hope for HIE are championing those things. So that's just another thought of a direction that it could go.
Absolutely, yeah. We've thought of that before. I think through conversation, whether we should be setting up more multidisciplinary type clinics. This is a major surgery, right? This is not amongst all the things we do in medicine. This is up there. So I think for us, I as a neurosurgeon, families come to me. They come to me with questions that I very honestly don't know a whole lot about. Visual challenges, or we know the basics, but auditory. But they talk about energy, thirst, all these things. So maybe you're right. Maybe what we do need is to create a perhaps a checklist, or maybe these multidisciplinary clinics that we can sort of guide our patients towards and sort of help them with these challenges earlier, and maybe we can change the course of these illnesses.
Funny you should mention that. We're going to have a symptom surveillance working group that we've talked about last summer. Hopefully meet next August to align on symptom surveillance so that we can publish and have standards of care post-op. So I hope everyone in this room can participate in that in some way.
I'm going to invite Emily. Please, Emily Harford will come and speak to us about functional outcomes, the UPMC experience. And I just got to know Emily earlier this evening, but I'm really looking forward to her talk. Emily is trained as a speech-language pathologist, and she works with Dr. Abel at UPMC in Pittsburgh, where, as you've heard, they clearly have a multidisciplinary approach and see many patients in a very comprehensive way. And I believe you'll talk to us about some of the issues that arise after hemispherectomy that we discussed.
Good evening, everybody. Thank you, Monika, for hosting this event and for inviting us to speak tonight. As Dr. Ibrahim mentioned, I am a clinical research coordinator working with Dr. Abel, and we're excited to be here tonight to present our experience and our findings looking at long-term functional outcomes in hemispheric surgery. I think this will go along nicely with what we just saw on a slightly larger scale, and that this is a look at a single institution and our outcomes. We were largely inspired to take on this project based on a paper that was published in 2022 by Monika and I believe a few other people in this room tonight from the Stakeholder Summit in 2019 that identified gaps in the functional outcomes literature. So our aim with this study was to provide a scoping and holistic account of what long-term functional outcomes look like for these patients. We were aiming to look at outcomes far removed from hemispherotomy. So for some of our patients, we were able to look as far as 15 years post-op. And we also wanted to look at outcomes that not only fill those gaps in the literature base, but would be meaningful and significant to patients and their families. Our cohort consisted of 34 patients. They were patients who had undergone hemispherotomy at UPMC between 2001 and 2022, so we have quite a large range there, and had at least 1 year of follow-up data. The seizure onset in these patients occurred an average of 1 year, but we have a range of birth to 11 years old. And the etiology we broke down into 3 categories. So most of our cohort had developmental etiologies, which would be things like congenital cortical malformations, hemimegalencephaly, and 35% 25% of them had acquired etiologies, which were largely comprised of patients who had experienced left or right MCA territory strokes prenatally or perinatally. And the progressive etiology is 2 patients who were diagnosed with Rasmussen's encephalitis. These patients underwent surgery at an average of 4 years old and an average of 2.5 years since the onset of seizures. And our cohort skewed largely towards the functional disconnection surgical technique. 32 of our 34 patients underwent functional disconnections, though 8 of those patients did return for a redo or a completion of an anatomic hemispherectomy. We also had a nice 50-50 split between left and right hemispheres. We won't spend a ton of time on seizure outcomes because this wasn't the primary aim of the study, but we do feel it's important to mention them because, of course, seizure control and seizure freedom contribute to some of these outcomes. And what we see at the point of longest follow-up for these patients, which was an average of about 7, almost 8 years, that 76% of our patients are seizure-free, falling into that Engel class 1, and that 18% are experiencing worthwhile improvement. This is at each individual patient's longest point of follow-up. When it came to selecting functional outcomes, again, we fell on the support of the paper that was published by formerly the Brain Recovery Project, but we also wanted to make sure we were addressing areas that we felt were important to patients and families. And so we relied on the World Health Organization's ICF model of disability, which is the International Classification of Functioning, Disability, and Health. And we utilize this because it's person-focused. It doesn't just look at what patients can't do. It doesn't just look at impairments. It tells us what they can do and what they'd like to be able to do. And importantly, it provides a common language that we can use across medical specialties, which we now understand is very important for this patient population. According to this ICF model, disability and functioning are multidimensional, and they consist of 4 primary components. The first are body structure and impairments, which I think is an area that we're all used to and classically used to documenting in research. But the second, third, and fourth domains are, I think, areas that are slightly under-researched and underrepresented in this literature. Those would be activities of people and any limitations they experience in activities. Participation, that's participation in the community and their surrounding environment, and environmental factors that are either facilitative or a barrier to their participation in activity. When we look at this component of the model, body structure and function and impairments of body structure and function, we looked at musculoskeletal and sensory impairments, and we see what we expect to see with hemispherectomy patients, that many patients, or 100% of our patients, developed hemiparesis and are experiencing visual deficits and spasticity, and those impairments persist through that 15-year follow-up. Now, we didn't look at improvement or worsening of these impairments over time, which I think is worthwhile. We treated this just binary, whether or not it was present. But we know that these are complications, that these are associated with hemispherectomy. We know that we can anticipate to see these impairments in patients. And these impairments are accepted in favor of those good rates of seizure freedom and seizure control. What we do also see is that a number of patients did present with these impairments at baseline, and that's largely due to the complex etiologies that they present with. Moving on to the second component of the ICF model, activities and limitations in activities. We wanted to look at a couple areas. Those were ambulation, communication, and self-help skills or activities of daily living. In terms of ambulation, what we see here, I think this is a great positive finding and echoes some other literature out there, is that all patients who were ambulatory prior to surgery remained ambulatory following surgery. That's not to say that they didn't demonstrate any abnormalities in their gait pattern, but nobody lost the ability to ambulate. You'll see that there is a high rate or high representation of non-ambulatory that's in the blue here at baseline, and that's largely reflective of the age at surgery. A lot of our patients underwent surgery before they had turned 1.5 years. So developmentally, we don't expect them to be walking at that point, but we wanted to include them in this category to help illustrate how these skills might develop and progress over time. And what we see with our cohort, 5 patients who were non-ambulatory at baseline did eventually develop the ability to ambulate with assistance, and that 7 patients who were either non-ambulatory or ambulating with assistance at baseline eventually became independent ambulators. In terms of communication, this was a little bit harder for us in a retrospective manner to evaluate and look at, but we see largely the same pattern with communication that we see with ambulation, in that patients who were verbal communicators prior to surgery did not lose the ability to verbally communicate. Having a speech pathology background, I do feel compelled to mention that we chose to look at verbal communication for this project. That is not to say that individuals who are not verbal communicators and communicate through other means cannot be functional communicators. So those are a few patients may be using augmentative and alternative communication, but for the purposes of this project, we did look at verbal communication. Most of our patients fall into this category of like the lighter green color that represents verbal communication, but below age expectations. So we see that not many of our patients are falling into verbal within normal limits, but they are still verbal communicators and can be functional verbal communicators. 7 out of the 11 patients who were below a year and a half at the time of surgery, so developmentally expected to be largely pre-verbal, did go on to become verbal communicators to at least some degree. This isn't to say that there aren't any impacts on language and communication post-operatively. I think we discussed that a little bit in the previous presentation. But the question of what happens with language and speech following hemispherotomy and even prior to hemispherotomy has a lot of contributing variables, and it's hard to parse out because these outcomes might be associated, of course, with the hemisphere that's operated on. We classically associate the left hemisphere with those language networks and language centers. Seizure control may be associated with better outcomes in terms of language and communication. And of course, etiology. That's really the large theme here, is that the etiology that these patients present with really contributes heavily to what their developmental course will look like. Looking at self-help skills and activities of daily living, this is an area where we did have a lot of missing data, which is unfortunate. I do feel it's a very important area to tap into. A lot of families might have questions about, further down the line as my child becomes an adult, how functionally independent will they be? Will they be able to live on their own? How much assistance will they require from me or other caregivers? So when we look at ADLs, we were talking about feeding, bathing, dressing, and toileting. And to make this a little bit more concise for this presentation, we categorize patients according to how many of those activities they required assistance or were dependent for. And the large pattern that we see here is that most of our patients do require at least some assistance with ADLs. What we found is that dressing was the activity of daily living that was noted most frequently as requiring assistance, and that's likely due to the fact that dressing involves a lot of fine motor coordination for things like buttons and zippers and tying shoes. But many of our patients did develop the ability or have the ability to self-feed independently, and a lot of them were able to at least participate in these activities of daily living like toileting, dressing, bathing, and hygiene. Moving on to the third component of the model, which is participation, the way we chose to look at this was our patients' participation in their educational environment. What we see here is that most patients do require some support services in their educational placement. This graph is kind of predominated by these green shades here. The lighter green represents children who are in mainstream schools but enrolled and receiving their education in a self-contained life skills or special education classroom. And the darker green below that are children who are enrolled in a mainstream school but receive support services. The type and the amount of services that these children required varied individually, but that might be something like pull out for certain topics or certain subjects, or perhaps a classroom aide or an instructional aide pushing into the classroom. We did have a few patients who were enrolled in special education schools, and those were primarily children who were enrolled in schools specifically for children with visual impairments. And we also see that a couple of our patients, just a small number, are receiving homebound instruction. And finally, onto environmental factors. When we think about things that might facilitate activity and participation for these patients, I think one of the first things that comes to mind are these therapy services: physical, occupational, speech, and visual therapy, facilitating independence, helping with development of skills. On this chart, I'll point out that the green bars that you're seeing throughout are representative of the percentage of the cohort that was receiving at least one therapy service, though I would say that almost all of them were receiving more than one therapy. And what we found is that at all of our time points, including baseline, over 80% of our patients were receiving at least some type of therapy and continued obviously to receive that therapy over a number of years following hemispherotomy. Physical therapy was the most utilized therapy service. However, occupational therapy is right up there with it in the gray, with speech therapy falling a little bit further behind that. And in pink, we have developmental therapy, which is early intervention. And the reason that completely drops off is that, of course, after a number of years, patients and children are not appropriate for early intervention. And these therapy services were typically delivered in a combination of outpatient therapies and therapies provided through the school or through perhaps an intermediate unit with homebound instruction. I do think that taking a look at therapy intensity and therapy frequency might be something valuable to look at, especially in the short term. One of our co-authors on a paper that we published on functional outcomes is a PM&R doc, and also pointed out that perhaps looking at a course of prehabilitation could be beneficial for these patients. We do see that there's emerging evidence that discharge to acute inpatient rehabilitation program has beneficial outcomes for these patients. We also looked at assistive devices. Of course, assistive devices can be any number of things that help with assistance in feeding or dressing, alternative communication devices, but we chose to focus on those assistive devices that were most reported and available to us in the electronic medical record. So we're looking at bracing, orthotic devices, bracing and splints for the lower and upper extremities, wheelchairs and walkers. We do see a slight pattern here of an increase in the use of assistive devices over time, but that comes with the caveat that, of course, as we get to 15 years, we only have 9 patients at that point in time, and we are missing some data, so it's likely that there's some inflation of what this looks like. But we do see that lower extremity orthotics were the most commonly utilized device in our patient population, and those were either unilateral or at times bilateral for patients. You'll see that a number of patients did utilize wheelchairs, and that looks slightly higher than the rate we reported for non-ambulatory patients, and that's because not all of these patients were using wheelchairs as primary mobility. Some of them were using them as an assist in cases where they were traveling long distances or they were experiencing some fatigue. And outside of the ICF model, we also did want to look at 2 other variables that we felt really contribute to capturing the picture of what the post-operative needs and preoperative needs of these patients are. And those are service utilization, those are medical specialties beyond neurology, beyond neurosurgery, and any additional surgical interventions these patients went under related to neurological sequelae, whether that was the hemispherotomy itself or just the etiology. In terms of service utilization, I think this is a nice picture for our single institution that kind of echoes the findings that we saw with the survey, is that most of these patients do require the support and the services and are being followed by other medical specialties. The table here shows you the most utilized services within our patient population, and highlighted in yellow are those services that were utilized or patients received services from for 50% or more of the cohort. Some of these patterns I think are reflective of our institutional practices at UPMC. For example, preoperatively, the plan is usually to be evaluated by PM&R, ophthalmology, and neuropsych, and you'll see that represented in this cluster at baseline. But we do see that those services continue to be utilized over time. And one interesting pattern that we did note is that once we get out to year 10 and year 15, we start to see more and more patients following with orthopedics. And this will lead us right into our next slide about additional surgical interventions. Overall, 55.9% of our patients did require at least one additional surgical intervention. If we look at the acute period, 30 days, going out to the first 2 years, those additional surgeries are really predominated by surgeries that were interventions for hydrocephalus and hydrocephalus management, so placement or revision of shunts and ventriculostomies. But we do see that a couple patients within the first year did come back for a revision for disconnection, and we see that pattern continue all the way through 10 and 15 years. Once we get out to 5, 10, and 15 years, we start to see that more patients are undergoing orthopedic surgery, which is what we saw in the survey as well. These were primarily tendon lengthening procedures or tenotomies, and this was an interesting enough pattern that we wanted to investigate further. We just presented a poster on long-term orthopedic outcomes in our patient population yesterday, and it's something that we would like to turn into a manuscript going forward, because this was not something that we necessarily anticipated going into this project. So all in all, though this study is limited by the fact that it's retrospective in nature and we have a large amount of data missing, and there may be reasons that that data is missing that bias some of our data a bit, I think there are some conclusions we can draw, which is that, of course, hemispherotomy comes along with these increases in impairments that we can expect and I think typically counsel families on, but that comes along with increases in activity and participation, which is in line with some of the literature that says that hemispherotomy, at the very least, is not preventative to development. These patients continue to develop skills. But that said, patients present with a wide variety of etiologies and complex etiologies. They have a lot of medical needs. They require the support of a lot of services. So I think it's important to evaluate what each individual patient's functional status is at baseline when we have discussions about what their developmental course might look like over time. And just to echo what was said at the very end of the last presentation, clearly there's a need for multidisciplinary care, and it would be really great to see other institutions coming up with multidisciplinary clinics to kind of reduce the burden on families of making appointments with so many different medical specialties. So we hope that this was a good starting point for us to fill in these knowledge gaps, and we also hope that this inspires other people to continue looking into these areas as well. Thank you.
Wonderful. Thank you, Emily. That was outstanding. That was really, really beautifully presented. We already have a question in the back. Maybe we can 2 or 3 questions to try to be a better moderator.
Hi, thank you. That was wonderful.
Thank you.
I wonder if you guys had looked at whether or not the children with language issues also had audiology issues, or were you able to evaluate that?
We unfortunately, retrospectively, the way we did the study, were not able to pull enough information on that, but I think that's a very, very important area and something that there's clearly a lot of community interest in.
And then there's
And we wrote a grant recently.
We did.
so there's a a language outcome scale called ORCA that's been developed for rats and is being extended to CDKL5, and it's a way to look at communication, nonverbal communication skills in a validated, prospective way. And I think it probably might be modifiable for this patient population too. I don't remember the speech pathologist's name, but she's at Duke and she's very energetic. And I'm sure if you reached out to her, she'd be willing to at least help.
That's fantastic. Thank you.
Oh, yeah, sorry. I'm Jim Baumgartner. I'm a pediatric neurosurgeon in town here.
Another question here.
Hi, I'm Steve Valier. I'm a PharmD by training. My question is, so how do you define, I'll ask it to any of you, how do you define seizure freedom after surgery? Is it the ILAE definition of seizure free for a year, or is it, I just always like to know how you define seizure freedom. So.
We look at Engle outcomes by definition of 1 year.
1 year.
Any additional questions or thoughts for Emily? Arya, please.
Emily, great presentation. Very important. I mean, we need to be collecting more and more of this, right? And so much of our research has been focused on seizure outcomes, and it's, you know, once the family, especially a year or 2 years out, they haven't seen a seizure, that's sort of, you know, now they're dealing with all the other issues more and more. So I think the next step from, I mean, this is good, but maybe the next step could be, what are the modifiable risk factors? Like, what can we, like, how much does therapy help? Like, is there a correlation between therapy and outcomes? Is it age? Is it duration of epilepsy? And sort of how do we focus on that, the modifiable risk factors? And maybe this is not a question you can answer with a single center data. You may need more. What are your thoughts on that? I mean, I don't think you looked at it specifically, and it was more just describing where they are, but what are your thoughts on that?
Correct. We didn't look at trying to make any predictions or associations between particular variables and outcomes. I think that's obviously a huge question, and we need to figure out what variable or likely set of variables contributes to outcomes for these patients. My first thought, just dealing with this data in general, is that we had so much missing data doing it retrospectively that it would be incredibly valuable to do more of this research in a prospective manner.
Rusty Novotny, I'm a pediatric epileptologist from Seattle Children's. I think a good, this is a great work, and I think it's really important. I think a good study would be comparative to perinatal stroke and looking at the long-term outcomes of those patients as well, because who hopefully have never had seizures. And so a large hemispheric stroke would be a good comparative population to look at outcomes, the type of therapies as well. And there are actually fairly large pediatric stroke registries where you could potentially get that data as well.
Thank you so much. That is actually a very thoughtful point. Okay, wonderful. Emily.
Thank you.
Thank you very much. We'll give Emily a round of applause. That was masterful. I am very privileged to introduce our next speaker as well, Dr. McNamara. Dr. McNamara received her medical degree from the University of Michigan, and she went on to complete residency in pediatrics and child neurology at the University of Michigan, and then an epilepsy fellowship at the same place, I think, right? Okay, excellent. But Dr. McNamara published what I believe is the only systematic review on non-seizure outcomes in children after hemispherectomy. Correct me if I'm mistaken, but it's definitely a very, very impactful contribution to the literature, and I invite you to come and tell us a bit about it today.
Great, thank you. You could have just said I did all my training at one place. I'm not ashamed anymore. So thank you so much for letting me come. I was privileged to actually meet Monika in this group back in 2019. It seems like a really, really long time ago. And I was able to go to the PCORI meeting where I am so lucky you taught me some of the things to counsel patients on. It was right around the same time that I had my first patient who had Rasmussen's and was going to undergo a hemispherotomy. I think a really important thing to know about me that probably no one in this room knows is I also identify as a sibling of a person with epilepsy who had a multi-lobar resection and had lots of side effects that I'm pretty sure were all predicted, but there was a significant lack of counseling. So I wanted to run very far away from epilepsy surgery until I saw how much good it can do. So I don't really have any relevant disclosures. And so as part of, and this is important because I think I have some ideas for some of the things we've been talking about, I'm part of the PERC Epilepsy Surgery Research Group, and we actually do a prospective study. And the first part of gathering all of the data was all the patients who have intractable epilepsy and gathering data about who gets surgery, what types, depending on all these different factors. And as part of that group, I was invited with my life partner, Aaron Fedak-Romanowski, who we do everything together, including run the epilepsy surgery program and now the epilepsy program at University of Michigan. And we were asked to review the non-seizure related outcomes in epilepsy surgery, which is honestly the thing that keeps me up at night. So as part of this paper, I'll just kind of go through the lack of evidence for some of the things that we do. But we kind of took all of these papers and broke them into quality of life, the effects of epilepsy surgery on quality of life, on different neuropsychological domains, and then also something that I struggle to this day, 7 years out, talking about what complications to expect. I know that sounds probably very rudimentary to some of you, but corpus callosotomy, who's going to become hypersomnolent, who's going to have worsening of focal seizures. So really important to me. I wasn't sure who was in the audience, but I think most of you know that not everyone needs epilepsy surgery, which is awesome. Actually, lots of people become seizure-free on medications, and good for them because it's awesome. Most of us in the room, that's not who we take care of. We take care of the subset of patients who go on to develop intractable epilepsy, and we know that continued seizures have negative effects on everything, on cognition, on behavior. They're on multiple medications which interact on family functioning dynamics, cost a ton of money, and also contributes to mortality. We'll just say that out loud, right? SUDEP. And again, nobody in this room I think needs to know this, but this is why you don't do epilepsy surgery evaluations after the 12th medication. You do it sooner because Quan and Brody and now multiple other people have shown that it's awesome when you're seizure free after the first medicine, and maybe that second medicine might, get another small group of people. But when you're on the third medicine and the fourth medicine, it doesn't matter which fancy medicine you maybe read about out there. We need to do something else. Stop just throwing medications at people. And epilepsy surgery is not easy. I'm 7 years out, and I love it so much. But it is really hard. And in pediatrics, I wish we had some straightforward cases where people had mesial temporal sclerosis. I get really, really jealous, actually. It's really individualized for every single patient, and it takes a lot of work. But what it's so satisfying is that the harder I work, the harder we work as a group, the better the seizure freedom rate is, which is actually just true. But the thing, we're not here about seizure freedom, right? We're here about the other stuff. And I struggle all of the time. I remember when I was first learning about epilepsy surgery, people were like, you're just done. Like, it's like epilepsy surgery and you're seizure free. But we all know that people are not seizure free after epilepsy surgery. Like, they're just not. And if you go somewhere and they tell you that your child's going to be seizure free, they're lying, right? So everybody in the room knows that. So this is very old now, but it's actually not irrelevant. The numbers have gone up maybe a little bit, definitely if you go to UPMC, but seizure freedom is like 60 to 69%. That's angle class 1. And for hemispherectomies at the time, I actually always thought the number was like way closer to 100. And there are some papers that show that it's close to 100, but don't quote 100, right? It's not 100. And I just had somebody come to see me 9 years post hemispherectomy, and he looks beautiful, and his development is amazing. And how in the world is he having seizures again? But he is. Temporal lobectomies, patients who have temporal lobectomies do quite well, but then when you're outside of the temporal lobe, you don't do as well. And so I remember the AES where everybody had like the iceberg, and they were all talking about how, seizures are just the tip of the iceberg and, all of these other things. I feel like the theme this year has been like, it's all about balance. It's all about the ratio of what are we going to do next for this patient who continues to have seizures? What surgery are we proposing? What neuromodulation are we proposing? And what are the knowns and the unknowns for that patient? So anyways, I'll get a little bit into the paper now, but the paper was really hard because we didn't know that you could hire a librarian to do all of this work. But we researched PubMed, Embase, and looked at all of the papers that we could find, and then we cross-referenced them and made sure we weren't missing any. And we kind of came up with around 120. This is a couple years ago now, during the pandemic. 120. I guess it was before. Yeah, it was during the pandemic. We didn't have anything else to do, so it was about 120 papers that we were able to include. Some of them had duplicate patients and whatever, but we were able to put them into some really broad basic categories that I wish we could have gone deeper, but we just couldn't, given the lack of data. So we tried to distill things into quality of life, papers that talked about cognition. We tried to be really inclusive, even if people didn't have very rigorous ways that they looked at things, and then looked at the deficits and complications, like reported in any paper, any paper at all. And so then we tried to be more clever, which was kind of challenging because people report their papers and their cohorts very differently, right? There were some really great groups, primarily from Johns Hopkins, who recorded about their patients who had hemispherectomies and hemispherotomies, and those were awesome to read. And corpus callosum, which we all know can be done in 3 different ways, and different various focal resective surgeries, and then ones where we could not tell what kind of surgery the patients had because they were combined. And then a bunch of others. And so the quality of life, I have one slide, which is, I feel like in peds neurology and peds epilepsy, we sort of know this because it was demonstrated in adults, and a couple of papers demonstrating this in peds, which is that patients have in their families, or the surgeon's perspective or the neurologist's perspective of how the quality of life of those families is better. And objectively, when people do that, like one paper, you're able to show that if you don't have to be seizure free to have an improvement, but if you have a 50% or greater improvement in seizure I said that wrong, but greater than 50% seizure reduction, then you have an improvement in quality of life, which is fabulous. But it was like inconsistently measured, and I included the 51 out of 52 patients in a large patients following hemispherectomy had improvements of quality of life, except for the one patient who was in a coma. And that's like a direct quote. So I'm not sure that they like pulled those patients and those families. Maybe they did, but they said quality of life, so we took it. So, but I think that that's probably true. I always worry though, like, is it because I'm the one who signed up to put my child through this, and so I'm going to, of course, report that the quality of life is better. So I think a lot of these studies are kind of fraught with problems. Neurocognitive outcomes. We were so excited to do this part of it because this is what Erin and I are really passionate about, and we like really wanted to know like how to counsel after a left frontal lobectomy versus a right frontal lobectomy. Like how much executive dysfunction are you going to have? I actually saw some stuff about that here, which was awesome, but it's going to let you down, so I apologize. But we tried to divide it into different categories. And you know, part of it, I like shouldn't be harsh on people doing research. It's because you can't do some of this neuropsych testing and cognitive testing because of the age of the patient, because of where you are, and insurance doesn't approve it. And so it's just kind of sad. And so especially for some of the large cohorts for patients who underwent hemispheric surgeries, like they're babies. And so there are definitely some modified testing that can be done, and they were done in some of these papers, but oftentimes it just wasn't done. And so part of it was because these were very large groups of patients who had surgeries in the 80s and the 90s. I didn't tell you this part, but I tried to like select some things that I like really learned or I thought were good take-home points. And so in the patients who had hemispheric surgeries, and this is one of my patients who had hemispheric surgery. He's unfortunately the guy who just started having seizures again. But anyways, in 28 children followed for 3 years post-op, many of them had improvement in language. And more likely, if the epilepsy duration was shorter, obviously this was like, we did this before your study came out, so would have been nice to add it to this. But more likely, if your seizure duration had been shorter, or if the cause was acquired, and also if there was a lack of epileptiform discharges on the opposite side, and preserved sleep architecture, which is like, that was a good one. They did a good job teasing that out, and it makes a lot of sense. So, but it's not all the patients had improvement in language. That's important. In 60 studies looking at combined, so this is not like multi-lobar or whatever. This is combined, like I couldn't tell what kind of surgery they had, so this is like, but I thought the data was good. So because what I had been taught, again, and what I was told to counsel is like, everyone's going to get better. Like that's so not true. It's awesome when it happens. It's like the most satisfying thing, but not everyone's cognition gets better. What you hope is you want stability, you want plateau, you want the lack of continued regression in children, but I never tell people things that I heard early on or at other places, which was, oh, your kid's going to start like getting tons better and doing better cognitively. That's a really terrible thing to promise somebody. But anyways, there were 3 large studies that we teased out in surgery in children who were less than 3, and there were mixed results, and you can see them right there. Like, I kind of want to go to wherever surgery happened at, study number 2, where 93% had developmental progress. That's like amazing. However, why did 2 other studies not show such an improvement? I don't know. Maybe there was a different surgeon. No, I don't. I'm sure it's the way that we're reporting things. So if I just was researching papers and trying to figure out how to counsel families, I would, if I just ran across study number 2, I would have painted a different picture for families versus the Kaddish study, for example. So again, fraught with lots of problems. Other neurocognitive outcomes, again, I'm very simple-minded, so sometimes I just have to think about lobe and which side. But in patients who had frontal lobe epilepsy surgery, this is end of one paper, sorry. If left-sided, you see a transient decrease in learning and delayed recall, but this improved by year 1. That's something I didn't know at all. And then in temporal lobe epilepsy, this is similar to adults, you see an improvement in language with the shorter duration of intractable seizures and if younger at the onset of surgery. And then similarly to adults, you'll see a short-term delay in recall and verbal memory at 3 months, but that tends to normalize and improve by 12 months post-op. I saw that in one of my patients, and his mom nearly lost her mind. But then at 12 months, everything was like better than it had been before. It's fantastic. Now talking about complications, and I'm trying to speed up here to give us some more time. But this is the one where how do you counsel like without knowing the complications? And so again, we tried to divide this into different categories. But in hemispheric surgeries, again, because I went to this talk, a couple of years ago, and met with this group, and I follow you guys religiously online. I knew some of the things to look for when we were doing this evaluation, the systematic review, but there was only one paper that reported on visual field loss, so we presume that all of the patients, right, have HHs, because I can't say the words wrong, and we also presume that they all have hearing impairment, but that's like nowhere in the literature. And then the post-op hydrocephalus and shunt placement numbers, like that's the thing that, again, you have numbers. People reported 0 to 28% requirement of hydrocephalus. Like, why? So I would want to take my child to the place that has no shunts. Like, what are you doing differently? We need to know these things. But if you looked at all of the numbers, it was really nice. These papers, I could look at all of the numbers. It was about a 20%. Required hydrocephalus. But again, the how long are we looking at? It just depended on the paper, and it wasn't that long. Some of them had like 10-year follow-ups, but then other ones were shorter. Another interesting thing that was really helpful that what you guys showed earlier, I'm always wonder about how many patients have residual connections. I feel like a lot of my life is like trying to find residual connections, and if anybody saw it, any of the neurosurgeons in the room saw it on that like previous MRI, please tell me, because now he's having seizures again. But in these cohorts following hemispherectomy, it was a very small number. It was 1.3%. Corpus callosotomy, again, I didn't know who all was going to be the audience, so I'm sorry. But corpus callosotomy is a palliative surgery done for disconnect the two hemispheres. Some people do the anterior 2/3, some people do the full. I also heard that sometimes people just do posteriorly, and it's something that, I don't know, we had several patients who needed these. And another thing that I was digging through the literature trying to find things, some things happened, and I was like, what? I can't actually counsel people. I can't find it in the literature to counsel people. And so the complications that people reported, thankfully, I actually haven't seen, which was hemiparesis, language deficits, and surprisingly, one person with permanent mutism. And then rare complications, which also, thankfully, I hadn't seen, was hydrocephalus. But like, I feel like now I know, because I've seen enough of them. Some of them like just don't talk some of these patients just don't talk for a couple days. I didn't know that. I didn't counsel people on that initially because I hadn't seen it. And so please publish this in the literature, right? Like, please start to report these so that I can counsel people appropriately, because I would lose my mind as a parent if my child woke up and was like just ignoring me, because that's what they do. And also, unfortunately, had this in one of my patients where the child had like way worsening of seizures for a good couple of weeks, and then all of a sudden she was like much better. That is also not in the literature anywhere, and that was not a laser ablation PS. So I need to know more. I don't want everyone to have to go through what I went through and see so many patients, and we need to be collective and start doing things, and also do things prospectively. Totally agree. And then complications from all of the 51 studies. Again, this is really fraught with problems, but 1.1% of the patients needed repeat operations. I suspect that is not accurate. That these were like, gathering of retrospect. I'm not going to publish on my patients that I needed to repeat operations on. I don't want people to know that. And also 15% of patients ended up with deficits, but this is, I would not like draw any big conclusions based on this. What I would draw conclusions on, which are the things I think that we know, which is earlier surgery is better. And seizures may or may not have an improvement on neuropsych outcomes. I think that's actually really important. And getting rid of seizures is always the goal, but even a reduction in seizures can be really meaningful. But I think we have so much work to do to track outcomes and complications so that we can provide appropriate counseling, right? That's what this is all about. And I actually think there's a pre-existing multi-centered group that I think we should tap into. There's a PERC epilepsy surgery group that I was talking about, and I think they're ready to move on to a new study. And I think what they should do, we keep gathering all of this data on all of these patients that we take to epilepsy surgery. I think it's now time to start to prospectively continue to gather the data on complications, weird things that, maybe you knew about at your center, but I didn't know that people oftentimes will get really sleepy after a corpus callosotomy. It's 4 weeks. And very importantly, it's not, you're going to have epilepsy surgery, everything's going to be all better. That is just the beginning. And I think that is a really, really important thing to counsel people on as the non-surgeon in the group. So that's it.
Wonderful. That was outstanding. Thank you so much, Nancy. Maybe open it up to questions. I was very interested. I mean, I didn't look into the literature this much, but one of the things I tell families after either a hemispherectomy or a corpus callosotomy is that the first 2 weeks are essentially unpredictable. That, the first 2 weeks, the brain is just getting accustomed to what we just did. There's a lot of unpredictability, and that's my way of counseling families about that uncertainty, because I have no idea not just what's going to happen, but which patient it's going to happen for. What are some of the predictive factors that would predict the sleepiness after surgery, or the aphasia after surgery? Did your review find any risk factors for complications?
Oh, not that I'm aware of, or not that I recall, but that's how I counsel now, which is, some people just wake up and they're eating a cheeseburger. Happened 2 weeks ago, or we're going to hang out and just watch your child carefully for a couple of weeks. I mean, that's how I do it now, but I wish that had been somewhere in the literature, unless I missed it, which is definitely possible.
I think it's really very, very interesting. Arya, please.
Yeah, just a quick comment. Just for us, when we're talking about functional outcomes, I think we really need to stop grouping patients and saying hemispherectomy, because a child with hemimegalencephaly is not the same as a child with an MCA stroke. Their seizures start different at a different age. They have their EEGs look different. The number of seizures look different. The timing. There's so many differences, and I think unfortunately that's sort of what we've done. We've sort of just grouped patients together and said hemispherectomy. But, these are just very different phenotypes. And one of the things I learned with the HOP study, putting all this data together across the globe, people having hemispherectomies, you actually realize that within each cohort, I don't want to say each country, but each region of the world, they operate, so when you look at Asia, they have a lot of patients with MCA strokes. They may not have a lot with subtle cortical dysplasia. There's other parts in the world that feel, they do more surgeries in those patients, or, some of the other etiologies are more common. So I think that plays into why these studies are so variable, because patient selection is different. There's places in the world that believe in doing palliative hemispherectomies. There's places that don't. So I think the data is, I fully agree with you. It's sort of so, the waters are so muddy that you're not going to see a clear signal until we start separating them as different etiologies, different diseases. They just have this common surgery.
And I think looking at them prospectively rather than,
Prospective, I just comment on that.
Yeah.
Prospectively is very challenging, especially when you want to look at long term.
Yep.
It's very, even for us, at our center, UCLA, our patients are coming from all over, and very difficult to bring them back and follow them up, especially when they're seizure free. So I agree with you, but it poses its own challenges.
Yeah.
Monika, you had a comment?
I think you can do it with the patient advocacy groups. We can help you. I feel sorry for Dr. Fala. He's my son's neurosurgeon. I'm never letting you go. You realize that? You're stuck here. I think we also have to look at, you mentioned hemimegalencephaly, when seizure onset happened. So even within the etiologies, there are differences. And whether they had infantile spasms, because infantile spasms is a whole other animal. So you can have a child with hemimegalencephaly or stroke who had infantile spasms is going to be very different than a child with stroke whose seizure onset was at 2 years old without infantile spasms. It gets really tricky.
I might maybe ask one other question, because we talked about the variability in etiology, but there's also the variability in surgery. I think all of us here, maybe by show of hands, how many do the peri-insular lateral hemispherotomy? Yeah, thought so. And how many do the vertical parasagittal? I mean, I think I know one. So Dr. Dorfer is here from Vienna, and I think probably has one of the world's largest experience with the vertical parasagittal, where you disconnect the basal ganglia as well. Does disconnecting the basal ganglia change functional outcomes one way or the other? Does it change seizure outcomes? I'm not sure that we know, but maybe did you want to comment on that?
Yeah, so these are definitely questions we need to tackle. At this point, we don't have these, and this is something we need to do.
Amazing. Thank you so much, Nancy. Yeah. Oh, one more question. Forgive me.
Thank you so much. That was an amazing review, and I really sympathize with how you felt, because I similarly was trying to delve through the literature and answer these questions, and like the corpus callosotomy, I was like, what? There's nothing or very little. But my question was for the PERC epilepsy surgery database. I know that they're collecting a lot of neuropsych outcomes, and specifically the people that are the centers that are participating in the neuropsych part of it. But are these measures incorporated already into that database?
What they've done, no, but I think that's the next phase. So it's, I think, and I'm going to misquote it, but somewhere in the 30s to 40s groups of multi-centered groups that we pro bono put in information about the patient's epilepsy. So we have the etaology and the MRI results and the age of onset, and if they have infantile spasms. And so we have all of that data. And then we basically looked to see who got surgery and what kinds of workups and evaluations. But now we've all agreed that we can't do that anymore. And so now we're going to collect data just on those who have surgery. And so I think it's an opportunity to say, and we're actually putting in follow-up data. So I think it's time to relook at our the information that we're putting in and start to put in, well, what type of hemispherotomy was it? I'll definitely have to ask my neurosurgeon. Was this a multi-lobar, or was this a corpus callosotomy? Was it anterior 2/3, or was it a full, right? One of those things that I completely changed what I recommend after doing it for a couple of years. But then also importantly, the complications and the deficits, counseling. I don't think I said this one out loud, I just thought it, but I had a little girl who came in who, she's pretty high functioning, but struggles in school. And we did a non-dominant parietal resection. It was a beautiful resection. It was like right where seizure onset was. And she totally had deficits afterwards that she shouldn't have had based on everything I know, everything the neurosurgeon predicted. And he was right where he was supposed to be. So I think I would have done a better job of counseling. It was really hard to find in the literature how she was going to do it. But I wonder if one day, which they have it in adult literature, they have these, prediction tools, right? These especially for temporal lobe epilepsy, how somebody's going to do. And I didn't know that they actually had a neuropsych profile to it now too. So how to predict what kind of language deficits they're going to have and that kind of thing. Wouldn't that be amazing if one day we had that for epilepsy surgery for pediatrics and all the variations and how high functioning the child was before, or if they had a hemiparesis before, were we actually going to worsen it or not based on the structural etiology and that kind of thing?
Thank you. And a follow-up question to you and other members of the PERC epilepsy surgery database, like Dr. Perry, et cetera, also our surgery colleagues and Monika here, but you had mentioned that prospective cohort or prospective study would be really difficult to do long term. And I also thought about the pediatric stroke databases, like what Heather Fullerton has done, which is essentially like prospective long-term follow-up for pediatric stroke. And obviously she's a huge research presence. And one of the things that's difficult about the epilepsy surgery database through PERC is because it's pro bono. So my question is, how do we fund this? Because there's a lot of people that want to help with it.
I have no idea. It's a problem, but I will continue to put it in pro bono, and I don't think it's actually too much to ask those of us who are already involved. I think we'll continue to do this because it's something that we should be doing, and we've been putting in data for a long time pro bono. But wouldn't it be nice? Yeah, I have no idea how to find money.
So this is actually a fundraising dinner. So I'm kidding. Thank you very much. Maybe another round of applause for Nancy. Really amazing work. So with that, we'll conclude the night with Dr. Falla, who will talk to us about a topic that we glanced a little bit earlier in the night, which is CSF diversion, the need for CSF diversion after hemispherotomy. And I was blown away by the numbers that you showed. 0 to up to almost 30% is what's reported in the literature. Where is the truth? So, Arya, please.
Okay, so my this talk is an update on post-hemispheric surgery, but I like to use that generic term because if you look at the literature, hemispherotomy, functional hemispherectomy, anatomy, the literature is not super clear, so I just use this broad hemispheric surgery. And this is a super important topic, and I'll tell you why in a second. I have no relevant disclosures. So we're going to discuss and review the evidence on post-hemispheric surgery hydrocephalus, understand what is currently known about it, and identify what still needs to be learned about it. So the neurosurgeons know this well, but just, introductory slide. Hydrocephalus really is the imbalance between CSF production and absorption. And usually, so results in increased volume and increased intracranial pressure, but this may or may not be associated with a change in the ventricular caliber. There is no cure for hydrocephalus. The only treatments, I should have put effective in quotations, but the only effective treatments are surgical. And it's a lifelong condition, very similar to epilepsy, and these children require lifelong follow-up. So in my mind, when we're talking about hemispheric surgery, one of the most important things is how can we do the surgery and not leave this child with hydrocephalus? Because then you're trading a lifelong condition with another lifelong condition. If you look at the health utility, which is a measure of the impact in terms of quality of life, epilepsy is just a little bit worse than hydrocephalus. So very important to try to prevent this whenever we can. So in terms of causes of hydrocephalus, it's usually either increased production, impaired absorption, or obstruction of fluid pathways, or some combination of. And what we know about hemispheric surgery is that it induces an inflammatory process, especially when blood and protein, blood interacts with the CSF space. And we know that they can also cause obstructions in the CSF absorption pathways. And also by disconnecting brain areas, this may have a deleterious effect on CSF flow dynamics. Okay, so this slide, I almost show it every time I talk about hemispheric surgery. There are about 25 plus, probably about 30 different hemispherectomy techniques, and probably more hemispherectomy surgeons out there than techniques. And this is really, our evolution has really been on removing less brain tissue and disconnecting more, right? And in terms of head-to-head comparison, I don't have any good data to say one is definitely better than any other type. But here's where I think we're not really serving our patients. The focus should be, how can I do a complete disconnection and minimize the risk of hydrocephalus, which is not really the focus of our conversation. And I'll say the onus is on us as neurosurgeons. We're very interested in techniques. Hydrocephalus is not a topic that gets a lot of attention, right? We definitely don't want to have, we don't have conferences discussing, hydrocephalus in hemispherectomy to the extent that we discuss techniques. But I think it's really up to us to figure this out. Because at the end of the day, it doesn't matter if the incision is incisionless, the incision's 1 inch, or it's 20 inches. The child without hydrocephalus and a complete disconnection is going to do better than the size of that incision. I think that's the most important point I want to make. Because a little bit about CSF shunts. Technology that has been developed in the 1950s with very little progress since. Permanent dependence on this implantable device. This has the highest failure rate in all medically implanted devices up until today. Estimated 50% of all pediatric CSF shunts fail within 2 years. And it's not a high risk of infection, but there's a risk of infection there. And infection, meningitis can negatively impact the child's cognitive outcome. So very, very important to try to prevent this, okay? The other thing is we had, I think, the same meeting that you were there, 2019, you alluded to. So this meeting that we had, stakeholder meeting funded by PCORI to try to identify knowledge gaps for functional outcomes. So we had a very diverse group of researchers, families, all of us came together, and the number one thing that was identified as where we need to spend our resources and our time and effort in helping our patients is in hydrocephalus. That was number one. Number two was mental health issues. Number three was literacy and other educational outcomes. So this is key. So what we had at the time, which we summarized, was that at the time we thought anatomic hemispherectomy and repeat surgery and underlying etiology may influence the risk of hydrocephalus. And other factors by expert opinion, which was, again, we agreed disconnecting rather than resecting the hemisphere, decreasing blood loss during surgery, and amount of blood in the ventricles and aggressive postoperative CSF drainage are likely going to help. So that was the data. We had very few studies to sort of support that those sentences that went into the manuscript. And since then, I just want to update everyone on sort of what's been published. So in terms of that's where we should start. How do we prevent hydrocephalus, right? This is a paper by Jay Hopman and his group in Seattle that writes 20% of patients can develop delayed hydrocephalus. And again, anecdotally, surgeons know to reduce the risk, we want to put a cottonoid in a foramen of Monroe, basically to prevent the amount of blood in the ventricular system, and use an EVD. And that's about it. Decreased blood loss. That's really it. Again, this is anecdotal, right? We published this paper, so starting in 2018, one of the things we did was, and whenever you do hemispheric surgery, no matter what technique you do other than the incisionless, you have access to the choroid plexus, which is what creates all this CSF and brain fluid. And one of the well-known treatments of hydrocephalus today is choroid plexus cauterization. So you have an opportunity, you're right there, you're in the ventricle, you know this operation has a decent risk of creating hydrocephalus. So what we started to do is cauterize the choroid plexus while we were there, ipsilateral in the ventricle. and we saw a huge and dramatic reduction of our hydrocephalus rates. At the time that we published this paper, we didn't have a single patient that had a first-time hemispherectomy who had hydrocephalus, but I will say, right after we published the paper, we had a couple patients present with it. So timing was key, but I will say those rates are much, much lower than what's reported in the literature. And to me, there's very little reason not to do it. And you will hear a lot of surgeons say, our rates are low, but even if you can prevent one other child from having hydrocephalus, I think there's very little reason to do this. Other advantages of doing this is you getting the choroid plexus out of your way, perhaps decreasing some of the blood loss and requirements for transfusion. So we've been doing this routinely. And then we also identified revision hemispheric surgery as a higher risk. And that's why that earlier slide where any child that has more than 2 operations almost always has a shunt. So you really want to minimize the number of times you have to go in. In terms of other risk factors, this was a paper by Dr. Sandeep Sood's group, and Nina's here as well in the audience. But so they found that 10 children, so about 20% of their patients required a shunt even after anatomic hemispherectomy. So it kind of challenges one of the future papers I'll show you that said 30% chance of hydrocephalus with the anatomic operation. So this is where they summarized all the data. And other than, if we remove the UCLA paper for a second that says 78% risk of postoperative hydrocephalus, I don't know that top line, and I'll explain that in a second. Most of the studies are in that 9 to 20% range. You see some that are even lower. You see one that's 0. But the major challenge is, so some of so UCLA was one of the first hospitals in the United States. So we're doing hemispherectomy surgeries in the 80s. And the surgeon at the time, Warwick Peacock, would leave shunts postoperatively. And that was not captured. So he would prophylactically, for a large portion of these patients, leave a shunt. So unfortunately, and UCLA still has a very large volume of these patients. So that literature has it's kind of been miscoded. So we kind of have this very high shunt rate where truly, and we're not doing prophylactic shunts anymore. So I think it's important to remove that piece of data from what we code. This is a study by Dr. Rutka out of Toronto comparing their conversion from the anatomic type approach to a perinsular hemispherotomy and seeing that their CSF shunt rates went from 24% to 5%. These numbers are very low because you can imagine adding one more patient here and the numbers would double. So, but again, showing that less resection was helpful. This is a study out of Miami. Dr. Shelley Wangs here from Nicholas Children's Hospital, showing that they saw that prior operations was a risk factor for hydrocephalus development, not using a postoperative EVD, and also if the child had an infection. So this is the Sean Liu study. So this was a multi-center study that looked at hydrocephalus rates across many institutions. And they found that about just more than 30% of patients develop hydrocephalus after hemispherectomy surgery. And the most common symptom was failure to wean the CSF drain. There was also sometimes imaging changes and headaches. And they found in this study that anatomic hemispherectomy had a higher risk of developing hydrocephalus, and also when the basal ganglia thalamus was resected. But a lot of this is just because that was the UCLA data. So that's what they would do there. So again, some of this is maybe less relevant in today's literature. Prior surgery made a difference, and in this series, use of hemostatic agents. They didn't find that a postoperative infection made a difference, whether or not an EVD was used, and an etiology was of the epilepsy. This is a study also from UCLA. Gary Mathern, who was the previous epilepsy surgeon at UCLA prior to me, and he found that etiology mattered a lot. And especially if there was a history of infection, the shunt rates or the hydrocephalus rates were much higher. And it was also different in cortical dysplasia. I'm going to talk very briefly about hemimegalencephaly separately because these kids are not, it's not only the etiology, when you operate on especially a very young child with hemimegalencephaly, the tissue is dysplastic. The blood vessels are not normal. The tissue is very friable, so blood loss can be higher, and this is also usually in a younger cohort of patients. So their risk of hydrocephalus is what we think higher than other patients of other etiologies. So this was we published this earlier, I'd say maybe this month actually, the 56 patients at UCLA with hemimegalencephaly who underwent hemispheric epilepsy. And again, some of this data is historic data, but functional hemispherectomy had a 30% shunt rate, anatomical was 38%. We didn't find a difference in terms of statistical significance, so we didn't find that technique made a difference. At the same time, we also did this systematic review on hemimegalencephaly, and in the systematic review, including a cohort of 145 patients, functional hemispherectomy had a 17% risk of developing or requiring a shunt, while anatomic was 52%. Again, so much of the literature is this prior UCLA data and the high shunt rates. So in terms of post-CSF shunting, what are the implications? So some of us have seen patients with pretty massive midline brain shift. And, for the most part, as neurosurgeons, we don't think too much of this. We don't really think it makes a difference. But we looked at it very carefully, and we saw that especially when you put shunts into the cavity, you tend to exacerbate this midline shift. And why does it matter? For the most part, it doesn't. But kids with very severe shift of their brain tend to have pretty bad headaches. Usually, and some of these kids will have pretty dramatic shifts where there's almost no cavity left on the other side. So we also found that the most common symptoms indicating the child had hydrocephalus is GI symptoms, nausea, vomiting, and loss of appetite. Failure to wean off the EVD, especially in the immediate perioperative period, and ventriculomegaly. So these were some of the more common signs. But even return of seizures, one of the very common things you have to do if a child who's seizure-free has seizures again is to rule out hydrocephalus. And in terms of what contributes to this midline shift, we found that shunts with low opening pressures in that cavity, and especially the non-programmable shunts, are associated with pretty severe midline shift over time. So in summary, some of the risk factors for post-hemispherectomy hydrocephalus. So excluding the data from the Peacock series, prevalence is about 2 to 22% in modern series. Some of and this is where the point I was making earlier, some of this is risk factors that we cannot change, right? So younger age at surgery may be a risk factor. Hemimegalencephaly may be a risk factor. There's some conflicting evidence whether anatomic carries a higher risk or it does not. And also not having Rasmussen's or cortical dysplasia. But in terms of where we should focus on is the modifiable risk factors. Here, we get a couple of studies showing that the anatomic approaches have higher risk. Those I put a star on because of the issues I mentioned with the original study. Infection, we think, increases the risk. Use of hemostatic agents, at least in one study. Repeat surgery been shown in multiple studies. Lack of post-op EVD has been shown, but we had a conversation with Dr. Dorfer earlier, and in his practice, and actually many of the European centers that do the vertical parasagittal approach don't even leave a post-operative EVD. So it's hard to know sort of where we stand completely on that. And at least in our study, lack of choroid plexus cauterization was associated with a higher risk. And anecdotally, again, all of us think decreasing blood loss during surgery, preventing intraventricular blood, and also, I didn't put it here, but aggressive irrigation at the end of the case may help. In terms of signs and symptoms of hydrocephalus, most common presenting sign is failure to wean the post-op drain, GI symptoms, and ventriculomegaly, as well as headaches. In terms of CSF shunting, again, to summarize, ipsilateral shunts within the cavity, non-programmable valves, and low valve opening pressures are associated with increased midline brain shift, and severity of this brain shift is associated with headaches and also language difficulties. The questions that remain: can we lower the incidence of post-hemispherectomy hydrocephalus through the establishment of evidence-based protocols? So every hospital, every surgeon has their own protocol in a sense, and this is not standardized in any way. Also, what's not standardized is what is the criteria for us to diagnose post-hemispherectomy hydrocephalus. So there are certainly patients with extremely large ventricles that, and I don't want to equate large ventricles to hydrocephalus, but what one surgeon may not diagnose as hydrocephalus, the other surgeon may. So we don't even have that standardized. And in terms of how do we treat it, hydrocephalus does not equate to shunts automatically, right? So in my practice, I'm happy to discuss this as well. If a child develops hydrocephalus, my approach is to go in and try to do a contralateral CPC and an ETV. And some of those kids don't require a shunt. So I think if you can prevent a child from having a shunt, that may be beneficial in the long term. But we don't have great data. We don't have multi-center data, so that's sort of evolving. And in terms of if you have to put a shunt, which valve do you use? Which side do we place the shunt? Many surgeons want to avoid the normal hemisphere, but I found that shunts actually work better when they're in a ventricle as opposed to a CSF cavity. And how do we minimize this brain shift? And should we be minimizing brain shift, right? So does it even matter or not? But most importantly also, what patient outcomes should we be tracking? It's not really the time to CSF shunt revision. That's the most important thing. It's the cognitive outcomes, right, which we haven't really captured in any meaningful way. So in conclusion, hydrocephalus is one of the most debilitating long-term complications following hemispheric surgery. Sparse research studies exist, mostly largely single-center patient cohorts with no comparative arms, and we really need large multi-center hypothesis-driven research to address knowledge gaps. These are the references from the studies I mentioned. Thank you very much. Happy to answer questions.
Arya, I just want to congratulate you because before Dr. Falla came along, I don't think anyone had an academic interest in the study of a very, very important topic, as you heard. So really, incredible work, and your contributions to this, I think, have been really remarkable. So really amazing.
Thank you.
Any questions from the group or comments? Yeah, Christian, please.
Yeah, thank you so much. I'd like to add something to the discussion that you beautifully addressed on Saturday, which is the need for redo surgery. And I'm seeing rates of 1/3, which is necessary in some series, which I think is very, very high. And I think it's our responsibility, no matter what technique we are using, that we're able to reduce this rate of the necessity to do it again. Because this is a major contributor to hydrocephalus, I think.
Yeah, great point. I will say, so that what I coded is actually directly from the registry that we did. That's patient-facing, so you can imagine sometimes there may be biases involved with who's filling out the survey. But I will say, especially now, I've had this conversation with Monika many times, and especially now with the widespread, epilepsy centers across the country, and we're taking now a very rare disorder, a rare operation, and we're now spreading that experience across many centers. And I think some of that, and this is, I always say this, I'm not shy to say this, there's operations you learn in residency, there's some you learn in fellowship. This is one you learn as an attending. And you actually learn it after you've done hemispherotomies where they have been incomplete. That's where you really learn it. So there's nothing wrong with that. There's a learning curve, but I think part of that too is sort of, I fully agree with you. I think a 30% redo rate is unacceptably high.
Right, because nobody in the world would accept partial resection of the temporal lobe when a complete resection was the aim, right?
Yeah.
I feel like I have to play the devil's advocate a little bit here. So, it also depends on the indications for doing a repeat hemispherectomy. So some centers, even if there's no residual connection, would attempt to go back and explore to make sure that there's nothing, or would convert from a functional to an anatomical. And the child may continue to have seizures because one might wonder whether that was a valid indication to re-explore. So I wonder if those numbers for redo capture those nuances in the indications for doing a repeat procedure. I don't know if either of you have comments on that.
I do have a comment. We actually discussed this on Saturday. But I'm interested to get, and we got Dr. Baumgartner here, some very senior epilepsy surgeons. I don't know what the threshold is for a redo. Before I give you my thoughts, it'd be nice to hear.
Yeah, please. We'll open this up for the group discussion.
So I came to Orlando because there was intraoperative MRI and I was frustrated by incomplete hemispherectomy experience. It's horrible for the surgeon. It's awful for the family. And it's just, there's a Cleveland Clinic series that has 53% failure, technical failure in hemispherectomy under 2. And that's a place with excellent surgeons and really good techniques. So I think the thing you want to do is do your very best to make sure that you've done what you set out to do at the beginning. And I think that with existing imaging, you can be pretty accurate about whether you've completed it or not. I mean, the indications for redo, if you think you've done it completely and the child's continuing to seize, you probably had, there's killing on the other side and you were doing a palliative procedure and didn't know it. When it comes later, though, it's tricky. And so the beauty for us, anyway, at our Center of SEEG is that that's a relatively, compared to the way we used to do things, painless or low threshold for discomfort, a reevaluation approach to get you to a place where you're confident that when you're going back, you're going to be successful. The worst thing, I think, is to have someone come back with delayed seizure onsets and then do another operation and discover afterwards that you've failed. So you really want to have a higher, as high a confidence as you possibly can that you're going to be doing something good when you go back. The other part of going back is it's hard, especially if it's a few years out. Your anatomical landmarks are very, very limited, and when you're flying off navigation, as soon as you open anything up and drain some fluid out, you're lost. So the intraoperative imaging for me is it's like taking your big brother to a schoolyard fight. It helps you sort of be more confident that you're going to get things done the way you want them to. But I think the redo, you really have to think pretty hard about it and collect pretty good data before you commit to it, unless it's an obvious failure in terms of the disconnection.
Wonderful.
Yeah.
Any other questions or comments?
I think Monica's got a
Monika,
comment.
please.
This topic is very close to my heart. My son is a triple hemispherectomy, functional hemispherectomy, the UCLA approach revision, then anatomical. He's on his 7th shunt revision, had a cranioplasty to make his skull bigger, which collapsed in its entirety. That was the first time I met Dr. Falla, was when he reconstructed his skull. I'd like to know how many centers here send your families home with a checklist of what symptoms might indicate hydrocephalus postoperatively.
On paper, or do you talk about it?
On paper or a refrigerator magnet. We'd love to work with you on something that you can hand them, because this is a really catastrophic after effect of surgery that the parents really need to understand. For example, that only 80% of the kids have imaging changes, so that 20% of those parents have a really difficult time advocating at a level 4 epilepsy center that only does 1 or 2 hemispheric procedures per year. And they're in the ER, and that doctor does not know what to say to them because their images look fine. And then they do a lumbar tap because mom has been in the hospital for 3 days and will not leave because we're on the phone telling her, insist on a lumbar tap. And the CSF shoots across the room when they do it. Yeah. So at a minimum, we would love send them home with a checklist with your name on it from your facility so that ER doc knows what to look for, that, for example, 20% of the kids may not have imaging changes. Yeah.
Wonderful. Thank you. Yeah, Nancy, please.
I definitely know that some kids don't have imaging changes, but how often do you do post-op imaging in asymptomatic patients post-hemispheric surgery?
There's no guideline for this, but I do it. I've started doing it annually for a couple of years, just to make sure we don't miss any changes. Yeah.
When do you do your first one post-op?
3 months with tractography.
Thank you very much. Okay, so maybe we'll give Arya a round of applause. Really incredible work that you're doing. And I think to close things off, maybe we'll ask Monika. Would you like to close us off with a few words? Sure. There's no pressure.
I just want to thank everybody for coming tonight. It's wonderful to see new faces, very familiar faces, 2 familiar faces maybe. We have some very dedicated teams that are in the foxhole with our families. And I'm very grateful for all of you for, I know I can be a little pushy sometimes, but our families really need you, and you're doing a great job with everything that you've done for us. I'd love to do this every year, just a quick update, maybe a nice fun way to close off AES. So we hope to do it in Los Angeles, which is my hometown, next year. Maybe we'll get a movie star or someone to come. Well, we have George, though, already, who's the movie star from his documentary, so.
And I think the LA AES meeting will have a pool party at Arya's house. So he's all right, wonderful. So thank you, Monika, for bringing us together. Another round of applause, please, for Monika and the speakers. Thank you very much. Have a good night.